I can start? Okay. Well, good afternoon, everyone. First of all, I want to thank to Dimitriev. I hope I have spoken clearly the way it should. For his kind invitation to participate in Cactus, this very important conference for the Ukrainian Regional Anesthesia Society. Well, my lecture will be focusing on regional anesthesia and obesity, and I'll just get away right now to start. So I want to okay. So I have no disclosures for the moment. This behind me, you can see it's where I live. I live in Oporto, in Portugal. I am where I am an anesthesiologist consultant at the Hospital das Forças Armadas, Polo Portugal, and also I am Secretary General of ESRA. So going right away to my lecture, this is a very important problem. I mean, obesity and overweight, because on the last 30 years, the prevalence of obesity and overweight has increased, has tripled the times. Also very important to mention is you can see there in 2016 part of the graphic, this yellow column represents the obesity in children. And what we have been observing for the last years is that the obesity in children and overweight has been increasing steadily, and it's a very worrying problem too. Obesity is not the same in all over the world. It has different prevalences, or whichever the continents and the countries, and is also different between men and women. Women experience more obesity when compared to men, and but also the geographic distribution is different, as you can see here in these pictures. But how do we measure obesity? Basically, we use this metric, the body mass index. However, it does not access body fat, but it's very easy and reliable for most people as a marker of obesity. When you look also at the statistics, you can see that there are a lot of people, more or less 71% of the world's population that is overweight or obese. And you can see here these three classes of obesity, 1 to 3, with increased body mass index, and 35% are on these two categories, the class 1 and 2, and also very worrying, we have a super obese, around 66% of the population. But the risks of obesity is not the same, considering the different the different types and the different persons. So you can see that Caucasians are in the bottom of the risks, and higher risk is the Asians. So Asian obese have more risks associated with this condition. So what's wrong with the obese population? Do they need special care? Do we need to address dosing? Are they more prone to complications? Does nociception and pain is different also? Well, what we know is that the obesity is associated with higher pain perception, but also the young, unmarried, with chronic opioid abuse and with past psychiatric disease suffer more from pain. So when we look at this graphic here, we can also see that when comparing, you can see on the left part of the graphic, comparing males to females, we have females experience more pain, and as they increase their weight, also the pain perception is higher. So when you look in the right side of the graphic, you can also see that as you go old and as you grow in weight also, you also experience more pain, being the peak between the 60 and 69 years old. How do we explain this phenomenon? There have been several studies, and what we know so far is that the excessive of food consumption leads to the increase of adipose tissue, and it's very rewarding when you eat. So there will be associated with a high endorphin level. That's what we give you a sense of well-being and of satisfaction. But adipose tissue produces leptin, and leptin produces dopamine, and dopamine is associated with the mood, substance use, eating disorders, and also the experience of pain. Leptin also and the adipose tissue are associated with inflammation, and this inflammation will provoke joint degeneration, and also these will contribute to the feeling of pain. So what we do when we treat pain with morphine is that we will increase the dosing of leptin and dopamine, potentiating all of these other conditions that I have spoken you before. What about this study referring also to complications associated with the obesity? So when they studied respiratory depression and respiratory arrest after surgery, what you can see here is that most of the cases were associated with the postoperative opioids that were given. So postoperative opioids can be associated with more severe outcomes when in the obese population. Here you can see on the right side of the square of the slide, the severity of injury. 14 patients were dead. 3 patients had a permanent severe brain damage, and only 6 had temporary or minor injury. So this is really associated with very severe outcomes. Important that you also should remember is that there are more or less 3 types of unexpected hospital deaths, and being the second and the third type more associated with obesity. And the third pattern is especially important to be aware that it exists, because the respiratory drive only happens when they are awake. So when the brain falls asleep, they will not breathe, and they will have a severe apnea and followed by death. These 2 types of unexpected hospital deaths are associated with clinical error and are most of the times drug-induced by overdose or in patients with hidden vulnerabilities. Other major complications associated to pain management in the morbidly obese are because obese are associated with obstructive sleep apnea most frequently, and associated with systemic opioids. This will increase the severity of this condition also. Important for you to remember is that most of the times we want to keep the patients under our closer surveillance in the first night. However, on the second and fifth nights, they have a high density of REM sleep, and this is also associated with a bad outcome. For general purposes, please remember that obese patients can be assumed as being a high risk for cardiovascular events, even though you cannot identify it so clearly. And also remember that fat cops are 10 times more likely to shoot you because they can't fight or run. So beware also with this type of thing. Multimodal analgesia can be a very good armamentarium because you can use several types of arms to fight pain and reduce the adverse events associated with each of the components. So you can also act at different parts of the chain of pain, and that way you can also reduce adverse outcomes associated with a particular medication, and also get the best with this association too. Considering particularly nerve blocks and regional anesthesia, so these are clearly associated with no or minimal respiratory compromise, as long as we are not talking about the interscalene block. I will address this in just in a little while. There are no minimal cognitive dysfunction most of the times, mild or no pain, so you don't have to give opioids. And no minimal nausea and vomiting. Patients are alert. There are minimal cardiovascular changes. They can eat and drink early, and they can walk early, as long as there's. You should be aware that lower limb blocks can increase the risk of fall. So you need to be aware of this problem too. What about dosing? So most of our dosing is based on weight. So this could be particularly important when we are speaking about patients with 100 or more kilograms. So I will present you here a way that you can easily understand how does your preparation of drugs fits on your patient in order to reduce the risk of local anesthetic systemic toxicity. So when you look at here at this table, you can recognize this the dose factor. Dosage factor is important for you to know to understand the risk of potential toxicity. So preparations with a low dosage have a higher potential for toxicity. So sometimes this could be a little bit difficult to understand. So I will give you this other way so you can, it's easier to understand how your dosage is adequate for that patient or not. However, my advice would be that you would calculate a dosing for an obese patient. Think about it as a patient with 70 to 75 kilograms. Looking at this chart now, let's suppose that you want to administrate bupivacaine 0.25 with adrenaline, or bupivacaine 0.5 with adrenaline or lidocaine. So on this middle part of the slide, you can see the maximum volume that you can administrate with that particular dosage or concentration. And on the right side, you can see also the kilograms. If you reverse you can also have in mind that there is a local anesthetic toxicity protocol. And here on the bottom part of this chart, you can also find a normogram for the administration of intravenous lipid at 20%. And also it is very, very easy to understand how much do you need to administer considering the different weights associated. Here in this table, you can also see the dosage associated with each drug in terms of total body weight, ideal body weight, and lean body weight, and how should be calculated according to the different types of drugs. You don't have to memorize all this. You just have to be aware that this is that these calculations have been done, and just consult if you need to administrate them. When you think about obesity and the performance of the techniques, it's well, the aim for success in a normal patient is as long as the more number of techniques you perform, the better you are. You know, so the expert you are, and the the higher success you have. But with obesity, you can try lots of times, but success might not be as good as in a normal person. When you talk about morbidly obese, well, our success is also lower, and we need a lot of experience, either for neuraxial or for peripheral nerve blocks. Considering now the interscalene block and obesity, well, although there have been some concerns that it might be associated with difficulties in respiratory difficulties, it has been, according to these two papers, it is safe, effective. Although the respiratory, the forced expiratory volume and the forced vital capacity can be reduced, but there was no increase in the respiratory symptoms or events. However, it can be more difficult to perform, and the analgesia might not be so complete as in a normal weight patient. So what are other problems with regional anesthesia in the obese? So the difficulty to visualize and identify palpate surface landmarks is higher because, you know, the volume of tissue is difficult. It creates difficulty because the structures will be deeper, and the landmarks are more difficult to identify. Well, difficult calculated dose is no more difficult. There can be difficulties in positioning also, because they don't move that well. The number of attempts will be higher, and there will be more block failure, even with ultrasound guidance. So we need to do is optimize everything. And by that, I will explain what I mean. So in order to reduce complications, length of stay, and reduce costs, all patients need to be early fed, and you need to give them early mobilization that you can achieve using the right techniques of regional anesthesia. Let's look at obesity like ERAS, okay? So you need to stimulate the gut motility, prevent nausea and vomiting, reduce the use of opiates, increase mobilization, use short-acting local anesthetics, and mid-thoracic and epidural analgesia or anesthesia can also be of good value. Here, I am just reminding you of the epidemics that we are facing so far. So obesity, opioids, and also COVID now are competing with bird flu and also global warming. Considering now the types of surgeries that obese can face, so most of them are dealing with bariatric surgery and other non-bariatric surgery. For abdominal surgery, including the bariatric ones, the best protocols for analgesia would be a multimodal analgesia. If you need opioids, you can use patient-controlled analgesia with no background infusion and a very close monitoring. Thoracic epidural analgesia can be a very good value, either with laparotomy and laparoscopy. And because it will give you an adequate level of epidural placement, that would be essential. It can be very challenging in the obese, and some reports have stated some worse outcomes, especially associated with wound infections. Here on this graphic, you can, so this is what in red, it means that it's strongly recommended. In purple, it's moderate, not very recommended, but it has a moderate strength of recommendation, and weakly recommended is in brown. So when you are considering laparotomy, thoracic epidural analgesia would be the best option, followed by TAP, and the least recommended is the catheter wound infusions. For laparoscopy, you can use thoracic epidural analgesia with a weak recommendation. Moderately recommendation would be intravenous lidocaine, intrathecal morphine, and TAP. And all strongly recommended is multimodal analgesia. For non-bariatric surgery, here you can see the different types. Also, the MMA means multimodal analgesia would be basically using regional anesthesia with systemic analgesia also. So the recommendations considering the different drugs are on the left part of the table. And otherwise in techniques, the recommendations more strongly are the neuraxial and also the peripheral nerve techniques like TAP is not all is as a recommendation C as the continuous wound infusions. Preoperatively assessment and information are extremely important. They have a very strong recommendation, especially if you want to engage the patient and the family, reduce the anxiety, improve the compliance, and prepare the patient for everything that he will face during his recovery. Well, so I'm going to share with you some magic tricks. I call it magic tricks, but actually they are not really magic tricks. They are basic things that I think can really improve your performance. So the use of equipment is really important. You need to have to utilize the proper equipment. So you need an ultrasound transducer for a curved one for deep structures, because these patients, even a very superficial block like the femoral nerve block can be very deep. Use adequate equipment with very long needles, as you can see on the bottom. And also for monitoring, use the blood pressure cuffs are also very important, and use very big ones appropriate for the large arms associated with this kind of patients. Also, if you want, you can perform your techniques, and here is just a simple way to reduce this very big belly lying over the inguinal crease, and just pulling the abdomen high up, you can expose the area that you want to block. You should avoid the prone position, because it is really hard for them to move and for you to handle. So instead of using prone, maybe you should use only lateral, like on the right side of the screen. Here you can see this is my neck. Well, it's not a very fat neck, fortunately, but this is just to show you how you can increase your scanning area. So you need to ask him to turn to make a rotation to the other side that is not to be blocked, like that, and then to increase the area of scan in these very short necks. You depress the shoulder and you ask the patient to reach for his knee, so that way you will increase the area for scanning and to make the proper puncturing area. Pregnant patients can also be very big. The maternal in obesity, maternal mortality is bigger. The mortality associated with anesthesia is also higher. They have prolonged labors. The complications are worse for the mother and for the child. And most of the times, the cesarean section is performed, and they choose a vertical incision that is also associated with a more difficult recovery. There are hormonal and mechanical factors that advise a lower epidural dosing. They are more associated with hypotension and fetal heart rate abnormalities. And you should prefer to use small aliquots of local anesthetic in the epidural space and monitor closely the block dynamics. But regional anesthesia should be the first choice for a cesarean section. So if in these patients, you should try to place your epidural catheter early on in labor, because they can cooperate more because they don't feel so much pain. And because you already know that this is going to be a very difficult technique, it will increase the time that you need to place an epidural catheter. So if you have a patient like this, you should closely monitor her, and early on, just place your epidural catheter, so that you also need time to perform and also to test if it's working properly. Always try to avoid a general anesthetic when you have an unplanned cesarean section. So you already have your epidural catheter on place, and you can induce the block early and with short local anesthetic drugs. What about the analgesia for postpartum management? So again, choose multimodal analgesia. Don't forget the thromboprophylaxis and the management of the catheter with these types of drugs. Promote early mobilization, and also chest physiotherapy can be important. Think about the baby, because if these patients are breastfeeding, the drugs that you administer can also pass to the baby. As you can see here, morphine is the higher, is very prevalent in the milk of the breast milk of the mother, and it can pass to the baby. So here is my proposed protocol if you want to give analgesia for these patients. Everything in a way to reduce the opioid consumption. So mainly the most advantages associated with regional anesthesia would be to avoid the cardiac ischemia due to hemodynamic swings. There is also associated with the decreased blood loss, decreased atelectasis and hypoxemia episodes, because better spirometric recovery, and reduced risk of obstructive sleep apnea. It will improve your analgesia postoperatively, especially if you use long-acting local anesthetics. So here you should think about if it's enough to use long-acting local anesthetics as a single dose, or if it would be more advantageous to place a continuous peripheral nerve block, like a catheter or an epidural. Avoid local anesthetic that are hydrophilic, and avoid neuraxial hydrophilic opioids like morphine. Reduce venous thrombosis and associated mortality. So I'm just finishing. And when two fat people meet, you can always draw a climax. And mainly you should remember that obese feel pain differently. You can perform interscalene blocks. They are very challenging technically. They should be monitored closely and prolonged in time, not only on the first 24 hours. Think about it between 2 and 5 days postoperatively, especially if you are administrating opioids. Their pharmacokinetics and the pharmacodynamics can be quite unpredictable, considering when you compare to normal patients. And also, don't forget that besides obesity, they have other comorbidities that can increase and potentiate postoperative complications and limit the use of strong opioids. Well, and this is everything that I wanted to share with you. Thank you again for listening. I hope this could be helpful, and I hope to see you soon and live. Thank you. Stay safe.